Pulmonary hypertension. Pulmonary hypertension is defined as a mean pulmonary artery pressure of at least 25 mm mercury at rest, as measured by right heart catheterization. The definition may be further refined by consideration of the pulmonary wedge pressure, the cardiac output, and the transpulmonary pressure gradient, that is mean pulmonary artery pressure minus mean pulmonary wedge pressure. The clinical classification of pulmonary hypertension is shown in box 1785. Further classification is based on the degree of functional disturbance assessed using the New York Heart Association NYHA grades 1 to 4. Although respiratory failure due to intrinsic pulmonary disease is the most common cause of pulmonary hypertension, severe pulmonary hypertension may occur as a primary disorder, as a complication of connective tissue disease, example systemic sclerosis, or as a result of chronic thromboembolic events. Primary pulmonary hypertension is a rare but important disease that predominantly affects women aged between 20 and 30 years. Familial disease is rarer still, but is known to be associated with mutations in the gene encoding type 2 bone morphogenetic protein receptor BMPR2, a member of the transforming growth factor beta TGF beta superfamily. Mutations in this gene have been identified in some patients with sporadic pulmonary hypertension. Pathological features include hypertrophy of both the media and the intima of the vessel wall and a clonal expansion of endothelial cells, which take on the appearance of plexiform lesions. There is marked narrowing of the vessel lumen, and this, together with the frequently observed in situ thrombosis, leads to an increase in pulmonary vascular resistance and pulmonary hypertension. Now, classification of pulmonary hypertension: pulmonary arterial hypertension, pulmonary venous hypertension, pulmonary hypertension associated with disorders of the respiratory system and or hypoxemia, pulmonary hypertension caused by chronic thromboembolic disease, and miscellaneous. Among the causes of pulmonary arterial hypertension, the causes are primary pulmonary hypertension, sporadic and familial; secondary to connective tissue disease, limited cutaneous systemic sclerosis; congenital systemic to pulmonary shunts; portal hypertension; HIV infection, exposure to various drugs or toxins; and persistent pulmonary hypertension of the newborn. Pulmonary venous hypertension, among the causes are left-sided atrial or ventricular heart disease, left-sided valvular heart disease, pulmonary veno-occlusive disease, pulmonary capillary hemangiomatosis. Among the causes of pulmonary hypertension associated with disorders of the respiratory system and or hypoxemia, the causes are chronic obstructive pulmonary disease, diffuse parenchymal lung disease, sleep disordered breathing, alveolar hypoventilation disorders, chronic exposure to high altitude, neonatal lung disease, alveolar capillary dysplasia, severe kyphoscoliosis. Among the causes of pulmonary hypertension caused by chronic thromboembolic disease, thromboembolic obstruction of the proximal pulmonary arteries, in situ thrombosis, sickle cell disease. Among the miscellaneous causes are inflammatory conditions, extrinsic compression of central pulmonary veins. Now the clinical features. Pulmonary hypertension presents insidiously and is often diagnosed late. Typical symptoms include breathlessness, chest pain, fatigue, palpitation, and syncope. Important signs include elevation of the JBP with a prominent A wave if in sinus rhythm, a parasternal heave, right ventricular hypertrophy, accentuation of the pulmonary component of the second heart sound, and a right ventricular third heart sound. Signs of interstitial lung disease or cardiac, liver, or connective tissue disease may suggest the underlying cause. Now, the investigations. Pulmonary hypertension is suspected if an ECG shows a right ventricular strain pattern or a chest X-ray shows enlarged pulmonary arteries, peripheral pruning, and right ventricular enlargement. Doppler assessment of the tricuspid regurgitant jet by transthoracic echocardiography provides a non-invasive estimate of the pulmonary arterial pressure, which is equal to 4 into tricuspid regurgitation velocity square 2. Further assessment should be by right heart catheterization to assess pulmonary hemodynamics, measure vasodilator responsiveness, and thus guide further therapy. Now, management. Specialist centers should direct the management of pulmonary hypertension. Diuretic therapy should be prescribed for patients with right heart failure. Supplemental oxygen should be given to maintain resting partial pressure of arterial oxygen. Above 8 kilopascal, that is 60 millimeter mercury. Anticoagulation should be considered unless there is an increased risk of bleeding. Digoxin may be useful in patients who develop atrial tachyarrhythmias. Pregnancy carries a very high risk of death, and women of childbearing age should be counseled appropriately. Excessive physical activity that leads to distressing symptoms should be avoided, but otherwise patients should be encouraged to remain active. Pneumococcal and influenza vaccination should be recommended. Nitrates should be avoided owing to the risk of hypotension, and beta blockers are poorly tolerated. Cyclizine can aggravate pulmonary hypertension and should also be avoided. Disease targeted strategies have focused on replacing endogenous prostacyclins with infusions of epoprostenol or treprostinil or nebulized iloprost, blocking endothelin mediated vasoconstriction with agents such as bosentan, ambrisentan, or macitentan, or enhancing endogenous nitric oxide mediated vasodilatation with phosphodiesterase 5 inhibitors such as sildenafil or tadalafil, or the guanylate cyclase stimulator riociguat. High dose calcium channel blockers may be appropriate in those with an acute vasodilator response. Selected patients are referred for double lung transplantation, and pulmonary thromboendarterectomy may be contemplated in those with chronic proximal pulmonary thromboembolic disease. Atrial septostomy, the creation of the right to left shunt, decompresses the right ventricle and improves hemodynamic performance. It may be used as a bridge to transplantation or as a palliative measure. This is the chest X-ray showing the typical appearance in pulmonary hypertension.